Good morning. Happy rainy Friday. I'm so glad you all are here. My name is Phyllis Newbill. I am the Associate Director of Educational Networks within one of ICAT's several centers. A couple of housekeeping things before we get started this morning. First, we are filming today's Playdate. So it will exist on the internet afterwards. So as you ask your questions and behave in the room, just know that that is something that will continue to exist. The clipboard is moving around, and I hope that you have signed in on it. Does anyone see? It's right back there right now. Good. So make sure that if you're in the room that you sign in on the clipboard. That helps us justify donuts and coffee, which is one of the most important things about an ICAT Playdate. Make sure you enjoy those donuts and coffee. Of course. When you have questions today, just wait for me to get to you with the microphone so our friends online can join us, can hear what you're asking, and good morning to our friends online. If you're online and you have questions, please just put that right into the link, into the questions link, and we'll get to those as quick as we can. If Professional Development Network credit is helpful to you, make sure that you sign up for today's, if you're a faculty member, make sure that you first sign up and also check in with me to make sure that I give you your 100% for being here. In the way of announcements this morning, we have a little event tomorrow. Just kidding. It's gigantic. Please come to the Virginia Tech Science Festival. It will be between 10 and 3 at the Moss Arts Center, Torgerson Bridge, and the 4th floor of Newman Library. We've got almost 60 exhibits. Zillions of children will be here, and the public as well. I hope that you'll come and enjoy that. It's a ton of fun. Today's Playdate, we've got Brendan, David, John, and Andy. I don't know how to pronounce your last name yet. Can you say it for me? Mullinaire. Andy Mullinaire is here as well. And I think there's some others on their team who are here as well. I'm going to turn it over to Brendan to get us started this morning.
Thank you so much, Phyllis. I think I'm broadcasting through. So hello, everyone. Brendan David John. I'm an assistant professor of computer science. We do have a few other members of our team in the audience. Maha is a master's student in computer science, and Dr. Boji, who is also a professor of computer science. And of course, Andy, who will kind of take the stage with me in a slide here. So we'll be presenting today on securing trustworthy XR interactions through human-machine networks in healthcare. So I don't have a clicker, so you're going to see me walking back and forth to my slides here, back and forth. But as we get started with our motivation, I want to make sure we all have a kind of common understanding of what we're talking about. I'm going to use the terms VR, AR, and even sometimes XR as abbreviation. These refer to virtual reality and augmented reality. We see these a lot as headsets that we put on that either transport us to another world, if it's virtual reality, or add virtual objects to the world we're currently experiencing, if it's augmented reality. So this is the type of thing that we're thinking about. And the team, if you actually saw the disciplines, we had some sociology in there, some biomedical engineering, and some medical school in there. We're trying to think about the use of virtual reality in these types of domains. So we are seeing an increase in VR being used for medicine, whether that's through the evaluation and training of new clinicians or surgeons. We're seeing this in treatment in some case. So we're actually seeing, I think it was roughly 39 FDA-approved VR, AR devices. So this is something like if you have lazy eye, for example, for young children, there are VR apps that will actually be able to kind of give you rehab and treatment through a virtual reality headset for this type of experience. The thing that we are actually going to end up focusing on a little bit more is that third bullet there of telemedicine. So we're thinking about this, we can do things locally, but does the technology give us anything new, particularly in the networks part of what you saw in the first slide, to actually work on telemedicine and connect people through these types of technologies? So the areas of interest that we're looking at is what is actually practical. I mean, VR is very cool, but if you've been following what Meta and the news have been talking about, there's been a huge, huge hype cycle for VR, but we're not using it every day. We're not seeing it in our homes yet. So what really are the practical deployments? And from the other side of things, from my own research and the way that I think about virtual reality and this technology, is what does it mean for trust, privacy, and security of the users? Users can be clinicians, users can be the dog that's walking in the front row, users can also be students, humans, anything of that nature. So we're trying to think about this space, what is practical, and do people actually trust these technologies? We're actually seeing a lot of mistrust even like when Meta or Facebook is putting their devices out. You might have seen these Ray-Ban glasses that people are wearing that are constantly being recorded. You might see funny videos of people actually putting on a full VR headset and walking into a coffee shop and ordering a cup of coffee with a headset that's blocking them from the world but streaming the video into them with a camera. There's some very funky things going on. So we want to understand this a little bit more. So in terms of the motivations and the applications, we have some ideas in mind in terms of rural access to healthcare in a particular scenario. So I do want to hand it over to Andy to give a little bit of the motivation, what we've been thinking about in terms of rural access and telemedicine.
Okay, so I'm Andy Millionaire. I'm a professor of practice in biomedical engineering, but I'm not an engineer. I'm a physician. I practiced pediatric pulmonology for 40 years, the last 30 at Carillion Clinic. And about 5 years ago, Carillion had a large grant from U.S. Department of Agriculture, and they were primarily doing telemedicine consultations with psychiatry. And as you know, psychiatrists, most of them don't own stethoscopes or otoscopes, so they were able to do a great job of expanding their services via telemedical, secure communications, but it really was an iPad talking to an iPad. As part of their grant, Carillion had suggested that they would purchase very sophisticated carts that would allow for more sophisticated telemedical consultations. And time was running out to execute that part of the program, and I had expressed interest in telemedicine based on some experience I had in the military. And so they came to me and said, we need to have a telemedical consultation quickly. So we set up in my office in Roanoke a unit, and we set up a unit in Lexington at a family practice. And one of my patients, a little 8-year-old girl with asthma, showed up in Lexington. After I had gone to Lexington, trained on this cart that had all the instruments with it, along with a nurse, Joanna, who trained with me. And so we established the connection, and we began the telemedical consultation. I did my history and all the things you normally do, and then when it was time to do a physical exam, Joanna fired up the cart, and I said, I want to look in her ears, and she pulled out the electronic otoscope, and I was able to see in the ears and look in the eyes, nose, throat, look at the skin with all these little instruments we had. We used an electronic stethoscope to listen to the chest. I had the results of her pulmonary functions on my desktop sent to me electronically. We had a wonderful visit. I was able to send prescriptions to her pharmacy and send an after-visit summary with her diagnosis and the plan for the future. And we signed off, and everybody was happy. About 6 weeks later, they came back and said, well, we told USDA that we were going to do 2 of these before the end of the year. Can you do this again? And I said, sure. We'd actually arranged a follow-up for the same patient, and so she showed up in Lexington, and Joanna didn't. Her backup, like me, had not paid close attention to all of the procedures required to run this cart, so we bumbled through it. Actually, the 8-year-old kind of helped mash the buttons because she remembered. And that was that moment when I went, wow, if I'm going to do telemedicine and others are going to do telemedicine, we need to do a better job of education and training. So I turned to my colleagues here at Virginia Tech who had expertise in the technology. Fast forward not too many months to the early 2020 as COVID slammed us. And on a Friday, I went into the clinic. I saw 14 patients face-to-face, did my history and physical and did the prescriptions and arranged the follow-ups and that sort of thing. I came back to work on Monday, and I did 14 phone calls as we transitioned to virtual visits. Well, 14 phone calls are not very satisfactory, but that's the best we had. But within weeks, we had a tool to use to do video visits, but without the tools. And on many of the video visits, when I would call and connect with a parent, the child would be next door, playing with friends, or it was still not very satisfying. And so we've moved forward, but the ability to do many of these procedures has limited us. We have surgical robotics now. We have the ability for surgeons to sit at a console and perform surgery somewhere else in the world, but we're still working here in Southwest Virginia. How do we reach out and take care of patients in rural areas? One of my areas of interest is global health and rural health, and so I recently did a little review regarding access to healthcare services in Southwest Virginia, and not only our patients, but even the folks who work in hospitals, and specifically, I've been working with Carillion Tazewell Community Hospital, and these patients going to that hospital don't have access to specialty care. They have great emergency care and routine care for medicine, basic surgery, pediatrics, but when you need a specialist, it's hard to find them. And this limited healthcare infrastructure and the shortage of healthcare professionals in rural areas can result in delayed diagnosis and treatment, and leading to poor outcome for residents right here in Southwest Virginia. For instance, deaths per 100,000 from chronic lower respiratory disease for metro and non-metro counties here in Virginia. In the metro area, which would include Roanoke, 15 per 100,000 deaths. Just a few miles south of us, double that, 29 per 100,000. In terms of travel, representative round trip. So we have, my specialty, I took care of, my primary area of interest was the babies coming out of the neonatal ICU who went home on oxygen, monitors, feeding pumps, other technologies, ventilators sometimes. If they were coming from Tazewell to come see in my clinic for typically a 30-minute visit, they would be in the car each way 2.5 hours. So 5 hours round trip with a baby on oxygen and monitor and trying to keep them warm, and the mileage round trip is 220 to 240 miles. So just think about that. If you were here in Blacksburg and you had to drive over 2 hours to go see a specialist with a baby in the car and maybe a 2-year-old brother who's with them, and or having a hourly wage job that if you don't go to work, you don't get paid. And so access to care is critical for us to improve the health of our residents here in Southwest Virginia, and that's what our project is all about.
Thank you so much, Andy. So yeah, we can see a lot of the context and why we're doing this type of work. It is suffice to say that we're not the first to think about XR for this type of application. So I have a nice little video here to show, no necessary audio. There's some really interesting work from the folks at Cornell Tech, and they actually looked at a use case. We were thinking about this project very broadly, and just in general, I was thinking about what I can do with the research and technology that I work on. And I saw this presentation instead of demos, and they're actually using a remote caregiver type of scenario. So there's some clinician we can see on the right-hand side. They would be located where their office or their clinic is, and they'd actually made some sort of networking connection to connect to some local environment. So say you're a caregiver and you're taking care of an elder in your family, for example, you might need some guidance to walk them through physical therapy exercises or to give some sort of treatment. So they had kind of started to realize this system. You're starting to see some visuals pop up, but you think about this as kind of, giving that clinician who's off in their own clinic a window into that person's room and what's going on to be able to give guidance. And they actually worked a little bit on how to kind of give annotations and actually give interaction between these folks. But what I thought was really interesting is instead of kind of taking just a first-person view, maybe, of somebody who's in the local environment, I see what you see, I tell you what to do from your perspective, they actually looked at this more from a third-person perspective. So the doctor is kind of some virtual avatar floating in the room, and can actually see it from a third-person environmental view. So they're seeing what's happening, and it actually makes sense for this application, right? I have to guide you through some sort of motion. It's easier to do that from across the hall than it is to be from your first-person view. So that actual demo itself, that's the end of the video, at least that I need to show, was actually looking more at the interaction and how can I like do something here in this remote environment and share that information over to the local in a very effective way. But this was some of the motivations that we had going into the actual project as we've started to realize this. So here's just a blown up view of their full model. You actually see things like scans, even in the top right. You can think of how the system could expand to share a lot of data in a multimodal sense. But very broadly, we were thinking about this, right? The actual setup for this locally means we're bringing technology into the home of our patients, caregivers, and potential health workers who might be assisting as caregivers. And from the remote side of things, we're bringing the clinician into the home, right? We're not just giving them, a phone recording or some sort of FaceTime or even, like a Zoom that you're doing right now, right? I kind of know what the perspective of a Zoom camera is because I see my video. We're actually bringing them into that home environment in some 3D spatial sense, which really started to make us ask some questions. First of all, is this particular application practical? Right, we're looking at this caregiving scenario. Is this technology supporting this? Is deployment feasible, right? We're talking about the way that we think about access, and we talk about all the mileage and gas that would cost, but at the same time, if this technology is super expensive, hard to set up, what is the actual feasibility trade-off? What novel risks are we introducing? As I said, a lot of my research background is a little bit more on privacy and security, and there are some really unique factors of this spatial 3D immersive technology that's slightly different from the kind of traditional mobile phones that we've been working with. So what is kind of showing up here that might be new to this environment? And I think most importantly, do users actually trust this technology, right? So if I'm going to trust what a clinician tells me to do and listen to them, are they gonna actually work with this? Are they gonna understand this environment? And is the system going to support that in the correct way? So these are some kind of our high-level motivations. Of course, we have a research objective. Here's a nice little figure that we've been thinking about. I think on the right-hand side, we can think about this very broadly. So we're focused in on this medical case and potentially even just this caregiver case and guidance case. But in general, if we're seeing these immersive technologies, virtual reality, augmented reality, we can think about training nuclear engineers, for example, which is something I worked with VR before. We can think about evaluating education and students and creating access in different environments. Now, of course, we're focusing in on one particular project, so we're looking at this kind of medical application, but broadly we're interested in just understanding this technology, trust, and what these implications are for the future of work and the other applications of VR, AR that we're seeing. So broadly, we're kind of asking, how do we actually secure the user trust? Some of my past work has been in authentication. So is the clinician that I beamed into my room that's telling me to do certain things or do things in a certain way or collect this type of data or give this data to them, is it actually the clinician that we think we're talking to, for example? So this is kind of the questions that we've been approaching. We do have a kind of the initial set of work here has been kind of sample and survey existing remote collaboration systems. There are many more papers than I've included here, but I wanted to give you some of the highlights without making you read too deep into them. But what we're seeing, at least in the most recent systems that are coming out as this technology evolves very quickly, even in half a year and year steps, we're seeing that we're actually giving them full access to the local environment. This point that I made about third-person access, right? I'm not just seeing what you're seeing or seeing one webcam into your room, I'm actually seeing your room itself. Going further to some degree, we're also seeing the trend, and this actually is kind of expected, right? I gave you these terms AR and VR. It makes a lot of sense that the remote clinician is going to be putting on a VR headset to kind of transport to another world, while you in your home are putting on this augmented reality headset, so you can actually add new things to your environment. We're not really blocking out the local environment to some degree, so we're seeing this trend across all of these systems. Some of them share different things, but we're at least seeing that trend where VR is remote and AR is local. Kind of going back in the past a little bit, one of them was very inventive and what we call 360 based. So like previously the ICAT used to have a 360 camera here. Imagine just slapping that to your head and walking around your room. So essentially you have this like 360-degree panorama view of your room that follows you all around because it's strapped to your head. That's an even example of a system that they're using, and you could alternate between the first-person and third-person views there. Of course, all of these kind of looked at different tasks as well. We tried to focus in on medical applications, but there are many that are sitting out there. So I don't need to go too deep into this, but even farther in the past as far as 2016, kind of as Andy had mentioned with tablets, where I can use mobile phones and think about this way, but we're seeing the trend through the years to actually be with these wearable headset devices. So I think we're all familiar with trade-offs to some degree. We've been thinking about this survey also in feasibility and privacy kind of lens. I think the funny example I have too, people are used to trade-offs for food, right? Food can be good, cheap, or fast. pick two is pretty much all you get. So I'm trying to think about these systems from that perspective. And the past literature surveys aren't necessarily looking at these feasibilities of deployments and privacies. So just for time, I'm not going to step through this a little bit. There weren't a lot of big insights here. We've kind of made some taxonomy and labeling of what these systems look like, from just wearing a full panorama around, wearing just a first-person view and just seeing what you're seeing, and also just setting up multiple cameras and sensors and not even putting anything on your head to begin with. So beyond that, we can also think of even just a webcam case, right? If you're just zooming in and doing some telemedicine, that's this bottom row here. Low risk in the sense that I use privacy filters, I blur my background, high feasibility in terms of laptops have those cameras, and potential low usability because it's not going to give us that full immersive environment to interact. So I'll move on from this a little bit just for time reasons. We have been thinking about this system. We took inspiration from Cornell Tech as well. So we built around this thing called DepthKit Studio. There's a few challenges with this. It takes a while to set up, but it gives us a lot of benefits. We have some prior knowledge of it, it's very high fidelity, and it gives us the flexibility to test a lot of these different configurations you saw on the table before. We currently have the system. We are collaborating with the folks from Aries and the VT University libraries, so this is a nice view into that scene. For time, I'm not gonna spend a lot of time here, but we can see what these sensors look like and see what a recording room might look like to actually stream in all this data and actually play with VR AR devices there. Again, for time, let me just play a little video here. So we do have some system progress. As of right now, we're essentially just recording people in what is our local environment and playing them back potentially in a VR headset. So right now, this isn't even a VR headset, but you're seeing what is essentially a person in that studio room doing some actions, and we're essentially looping it over and over like a GIF. So we're still developing what this looks like for VR and actually getting live data working and making it in a reproducible way. So just for time, we have a few study directions. Again, we want to measure the trust perceptions of this technology, as well as actually do some forecasting work for the risks that we'll expose in the future. Apparently, I've lost my slides. Okay. But from that point, I will say we have some fun ideas in terms of what are the effects perceptually of using spatial technology versus traditional telemedicine. And the other things we're thinking about is different privacy filters, right? Like, do I actually need to see the local user in full photorealistic sense? Do I need to see avatars of them? Likewise for the actual clinician zooming in. Oh, there we go. Cool, okay. Yeah, so I'm just gonna fast forward to that just a little bit. But we're thinking about usability studies, focus groups, as well as forecasting this. And a lot of the fun ideas we have kind of come from other research ideas. We think of that little check mark in the top left of your Zoom that says this call is encrypted. Could we do a similar check mark for your clinician avatar that's floating and giving you instructions, for example? This is also not a new concept, but this might be new for this domain and this set of users. So I think with that, I just want to say our research plans will evolve over the next few quarters as we go from there. But for the sake of time, I want to just get to our questions and discussion. But yeah, thank you all for your time, and we'll have to take some questions.
Thank you, Brendan. What questions do we have in the room? Or if you're online, make sure you click on that link and send us your questions there. I have several, but.
Thank you. I wonder if you could speak a little bit more about the perception of trust. And I noticed in one of your slides sort of the next steps about the naturalness of an avatar versus something simple. I'm wondering what you're learning about sort of the connection between two people and trust and the visual nature of that image.
Yeah, that's a really good question. So a lot of the work that I've looked at specific to trust has actually also been virtual in a medical domain, but not in the 3D virtual sense. So there are a lot of folks who use actual virtual avatars in medicine for training nurses on how to deal with people, actually, as well as, of course, some automated avatar robot that gives you feedback. Instead of just a chat bot, it'll actually be a person talking to you. But in a lot of those studies, they tend not to be photorealistic. They have to be just human enough to not just be a floating blob of people, right? But they have to be they have to actually act, I think. What I think is they have to actually act normal. So it's a little bit less about the display fidelity is what those findings are seeing, but the effective teaching tools are someone that actually feels like I'm getting natural feedback from a real person. So in terms of the balance here, making sure that the real person is being represented, we're not really replacing them with agents in this kind of context. But what is the level of fidelity, right? Can we still get away with just good enough? Or because it really is a real person, it's a real person, is not a simulation, not a training tool, do we have to get a little closer to the photorealistic? But that's the way I've been thinking about that for now, if that answers your question.
So for the majority of these options, is the recording technology provided by the practice itself, or is it dependent upon whatever the patient owns?
Do you have any thoughts on this?
I didn't get that. Can you ask that question again?
Do they have to have their own stuff, or does the practice provide it?
I think that the practical deployment, if there's any telemedicine.
Does that make sense?
It would have to be, the practice would have to have that. I don't think we would have that in individual, like I wouldn't have that in my home. We'd have a center where we would do that. And there are many practices around the United States now where they have telemedicine hubs. Carilion is developing one in Bluefield where specialists can tune in there and patients can come to Bluefield to have their specialty care. It's still, they have a way to go, but that's a model that makes sense to me.
And I'll just say from the feasibility side, what I've been thinking is more like just price and cost, because we don't know what that model is always going to look like. But indeed, there's going to have to be some software, some connections that kind of come through the clinic, of course. Yes.
Thanks for this. I can imagine a world maybe some years from now where this works really beautifully and it's normative and we all take it for granted, but there's this like incredible road between here and there. I think the first place my mind goes is like this issue of trust with patients, but the other end of that connection, that human connection, is the physician. What I understand about physicians these days, there's not enough of them. There's so many patients to see in a day. How have you thought about physicians trusting and wanting to participate in a system like this?
I'm glad you brought that up. That's a real issue. And as before I retired and left Carilion, we were having discussions about that. Is how do we create a system that doesn't go wrong? It went wrong with Dr. Andy. The first time it went great, but it had a lot of support because it was the first encounter they'd ever done. And so I had plenty of technical support. The second one, not so much. And I really wanted to do that. But that's what really stimulated the thought. We need to train people. It's the trust of the physician that when I tune in, everything's going to work. And that person operating the cart is in tune with me. And the person operating the cart is also in tune with the patient. And so there are, all these dyads, physician to cart operator to patient, patient to physician. You throw in pediatrics, and now you got a parent-child dyad. And all of these, and that's the real importance of doing this kind of work, is to create systems that work first time, every time. And the physicians are willing to do it. Right now, there's a lot of resistance because of these things. Well, does the stethoscope really work? Can I look in an ear? Can I do the things I want to do? What about if I need to touch the patient, feel a liver? How are we going to do that? And there are methods for doing that, but the trust building is really important to this whole process.
I wonder, given the questions, if there's kind of a middle ground, which is to deploy, and we've talked a lot about that in ICAT and with faculty with ICAT, of deploying centers that are remote. So small places that you don't have to boot, that are always working. The interface there is the same. Patient or anyone can come to that place, or the physician can come to that place. And the same thing at Carilion. There's a place there, or places there, that are always the same. You don't have to boot them. You don't have to upload Windows, 11.73. It's just there and working. So how about that as a middle ground, and what kind of research has been done on that?
That makes sense. I haven't looked too deeply into what's actually going on with that, let me say, as far as existing research, but that makes perfect sense, right? Like the feasibility can definitely be accommodated that way, as well as the trust, right? You show up and it works. And I know that I don't have to be the one to set it up and make an error. I didn't get to make my point about calibration, but even like breathing on one of these depth sensors like sets off the whole system. So you almost need people on staff to be able to work with them, to be able to understand that, and understand what that networking system might look like in that context. Yeah, that makes perfect sense.
We are right at time. So I want to take just a minute to thank you all for being here, and also acknowledge the Center for the Future of Work, that I think I just said the name wrong of, because it's close. Okay, all right. So ICAT does have several centers in it, and so this is, I think, is this our first Playdate? No, it's not our first Playdate. It's among the first Playdates from the center. So thank you for representing so well. Please feel free to enjoy bagels and donuts and continue the conversations.